Today's webinar presentation entitled Review of Photobiomodulation Literature, Implications for Treatment Plans. My name is Phil Harrington. I am the Medical Director for Sumis Medical Laser, a position that I've held for nearly 15 years. It's so wonderful that you've joined us today. This will take about 30 or 35 minutes. The webinar is being recorded and you will get the link to view it again later. You do have the standard places to type in your chat or questions during the webinar, so I certainly welcome that. Now, the first thing that I'm going to do is take a little bit of artistic license and slightly modify the title of the presentation. And I will add in the phrase real-world clinical experience. So instead, we will call this Review of Photobiomodulation Literature and Real-World Clinical Experience, Implications for Treatment Plans. Now, whether you have been using Class 4 laser therapy for a long time, or if you are new to Class 4 laser therapy, or if you are considering it for your practice, I plan to give you many helpful ideas and tips and thoughts about the application of Class 4 laser therapy. Sumis Medical Laser, we are the elder statesmen. We are the company with the most experience in Class 4 laser therapy in the United States. And I've been the medical director for this company for nearly 15 years. In September, I will be celebrating my 15-year anniversary. So we do have a lot of that real-world clinical experience. One of the favorite phrases that a friend of mine said, and this gentleman had a PhD in physics from Vanderbilt University, so he was certainly an intelligent fellow. And he said that if we waited for double-blind studies on every medical procedure that we do, we truly would be still in the Stone Age. So I certainly place great value on double-blinded studies and other studies for validation of what we're doing in photobiomodulation. But if we wait for those studies to come, then we would be stuck in inaction. And I'm going to talk about some examples of that as we go through the webinar today. So let's get rolling. On most of the slides, I have a green box, and I tried to find a color that was a little closer to Masters green, with this being the week of the Masters golf tournament in Augusta, Georgia. I'm not sure how close I got there, but on most of the slides, you will see a green box, and that is going to be your take-home message. So it's, I'm presenting information on the slide, and it's that information in that green box. That's what I really, really, really want you to know. Now, here's a summary of my curriculum vitae, if you will, my work experience and what I've done. And as I said, I'll be coming up on my 15-year anniversary as the medical director for this most wonderful Class 4 therapeutic laser company. The first thing I want to start up by saying is that you must have a Class 4 therapeutic laser. Why do we use Class 4 therapy lasers? The statement is this, and this is a message that has been consistent from me and for all of us in our company, all of the experienced doctors and clinicians in our company. Why do we use Class 4 laser therapy? It is to deliver a therapeutic dosage of red and infrared laser light to a larger volume of tissue and to deeper targets in a short treatment time. Years ago, I think it was 2006 or 2007, a gentleman by the name of Dr. Julian Vickers. Dr. Vickers is now deceased, and you can still find this article if you do an online search. We talked about how Class 4 therapy lasers maximize the primary effects of laser therapy. So your whole goal with laser therapy is to get photons of laser light being absorbed by different components, and we call those components chromophores. We want this laser light to be absorbed by the tissues. And the take-home message here is that Class 4 laser therapy maximizes the primary effects of laser therapy. And that's how we are able to get more consistent results. We're able to get better pain relief. We are able to get better resolution of inflammation. And so really my take-home message here, with the class 4 therapy laser, we are maximizing the primary effects, but also the message is if you're not offering laser to your patients yet, if you're not using a laser in your clinic, you must look at class 4 therapeutic lasers. And let's look at another example why. This is a slide that I frequently use to compare class 3 therapeutic lasers to a class 4 laser. If we simply do the math and look at the amount of energy that is delivered in a 5-minute treatment time, and then the area to which a target dosage of 5 joules per square centimeter can be applied, it's just as simple of the calculations. A class 4 therapy laser delivers a therapeutic dosage to a larger volume of tissue than a class 3 therapy laser. And once again, that's why we are maximizing the primary effects. We are getting a larger volume of tissue where we are getting direct interaction between photon and target cell. Another way to think about this, let's say we have the Superdome. We have this basketball game that was played in the New Orleans Superdome. Of course, on the slide here, I'm showing you a football game. Let's do a little thought experiment. Imagine you're inside of the Superdome and imagine that all of the lights are turned off. And then someone dangles a 40-watt light bulb from the ceiling of the New Orleans Superdome. Would a 40-watt light bulb illuminate the entire Superdome if you simply left it on long enough? And of course, the answer is no. In a similar way, a therapy laser with too little power cannot adequately treat deep body structures. In other words, take home message. If you have a class 3 therapy laser, you cannot simply leave it on longer. You must upgrade to a class 4. Now, this message of the necessity of class 4 laser therapy is something that me and other people, the founder of Sumus Medical Laser, Dr. Albright, and other doctors such as Dr. Julian Vickers, Dr. J. Rod McGinnis, who is also now deceased, Dr. McGinnis being a fan of class 4 laser therapy. There are many of us who were involved in this technology from the very beginning when we got FDA clearance in March of 2005. So since 2005, our message has been consistent that you need a class 4 therapy laser. It was so rewarding. This article was published in February of 2019. So 14 years after we were giving this message that you must have a class 4 therapy laser, this panel of experts from around the world, Dr. Anders, Dr. Arani, Dr. Baxter, and Dr. Lanzafame, from all around the world, different disciplines, different degrees, they wrote this article that was published in February 2019, and they said photobiomodulation therapy is performed not only by class 3 lasers, both class 3 and class 4 devices are being used successfully to treat patients in human and veterinary medicine. And here's the key line here. An important advance in photobiomodulation therapy was the recognition that optimization of transcutaneous therapeutic parameters should be based on the photonic dose reaching the target tissue, and that often requires higher doses of light at the skin surface to reach deeper tissues. So here we have this validation from these 4 worldwide experts on photobiomodulation that yes, if you want to get enough light deep into the body, you must have a class 4 therapeutic laser. Let me just throw in a quick side comment here. If you've heard me speak before, maybe you've heard some of these things before, and maybe this is going to be some review and reinforcement for you. And I think that's okay. It's okay to have this message reinforced. So many years ago, we did conduct depth of penetration studies. So in this paper in 2019, they did say that you must have a higher dose at the skin surface in order to deliver enough light deep into the body. Well, many years before that, we did conduct the depth of penetration studies. And here is the depth of penetration curve from that study. It may look a little bit complicated. Let me try to break it down for you. It's called the y-axis, the up and down axis on the left-hand side of the slide. That's where you see the percent intensity going from 0 to 100%. And then on the x-axis, you see the depth in water. But then also this is going to be the depth in tissues from the depth of penetration study that we did. So the key point here is that if you follow the line from 10 centimeter depth and then follow that back to the percent intensity, the key point is this. At a 10 centimeter depth, which is about 4 inches, you have 30% of the incident laser light remaining. Okay. So when you shine laser on a skin surface, it's not a depth charge. It's not going to go down to so many centimeters and stop there. Rather, once you shine that laser light on the skin surface, it will get dimmer and dimmer and dimmer as the light goes in and as those photons get absorbed by the different components in the tissues. So one way to think about this is if you wanted to have a dosage of 3 joules per square centimeter at that 10 centimeter depth, then you would need a dosage at the surface of 10 joules per square centimeter. Of course, 3 is 30% of 10. So this is a little bit of your take-home message there. All right, so for the webinar, once again, if you've seen me present other webinars, this is kind of a summary of some of the other things that I've presented. And once again, I think a little review and reiteration every now and then is just fine. The first message that I want to get out here is that in 1978, the Rice protocol, rest ice compression elevation, was invented by Dr. Gabe Merkin. Now, 1978 is when he developed the Rice protocol. Now, many of you on the webinar presentation today, maybe you were not even born in 1978. And sometimes it can be kind of hard for us to, to think about how things were way back in 1978, 44 years ago. I'll do the math here quick. Yeah, 44 years ago. So what I did, and this is just being a little bit silly here, if we take the Rolling Stones, the picture on the left is the Rolling Stones in 1978, and the picture on the right is the Rolling Stones today. Now, of course, the gentleman on the right, the drummer, Charlie Watts, of course, has passed away. But I'm just using this picture to give us kind of that time machine thought, or in other words, how long has the Rice protocol been recommended? So what I really want you to know now, and here's my take-home message, the inventor of the Rice protocol, Dr. Gabe Merkin, now advises against the use of ice on acute injuries. And if you go to his website, drmerkin.com, he has an excellent article. And you notice he wrote this back in September of 2015. Why ice delays recovery. It's a highly referenced and very intelligent article on why we should not be putting ice on acute injuries. And so that's a message that I like to share because when I am out either lecturing on laser therapy or visiting doctors' clinics or visiting with other professionals, I'll ask them, about the Rice protocol. And so many of us are still using ice in our offices for acute injuries. And we just need to stop that. What do we need to be doing instead? I would recommend that we're using photobiomodulation or laser therapy instead of ice. So here's a nice article entitled Photobiomodulation, Inhibition or Resolution of the Inflammatory Process. And just to pull out a few key lines here, inhibiting the inflammatory process is not the same as resolving the inflammation. In other words, putting ice on this sprained ankle that we see on the right, putting ice on there is not the same thing as resolving the inflammation. And a few more lines from Dr. Lopes Martens's paper. Use of nonsteroidal anti-inflammatory drugs inhibits inflammation and it also impairs the resolution of the process. And so you end up with this situation of perpetuated inflammation in that injured area. Photobiomodulation can act as a therapy, resolving the inflammation and not inhibiting the process, which is a huge difference. And that photobiomodulation is able to reduce or inhibit production of important inflammatory mediators such as interleukins 1 and 6, PGE2, and the matrix metalloproteinases. So the really key point here, photobiomodulation should increase the expression of these receptors and enhance production of resolvins. Taken together, the evidence raises the hypothesis that photobiomodulation actually resolves and does not inhibit inflammation. So I would recommend, instead of putting ice on these acute injuries, let's be lasering them as soon as possible instead. So here, you notice the entire text box is green, so that's the whole thing is a take-home message. Photobiomodulation does not reduce or inhibit inflammation like nonsteroidal anti-inflammatory drugs. Please do not describe laser therapy treatments as anti-inflammatory. Rather, it is better to say that laser therapy helps the body progress through the stages of inflammation, proliferation, remodeling, and maturation more efficiently. So acute injuries, get laser on there as soon as possible. Another take-home point is that with the various regenerative medicine procedures, whether it's prolotherapy, PRP, stem cell injections, with these regenerative medicine procedures, we can and we should be applying laser immediately after those injections. So yes, do laser those patients immediately after the regenerative medicine injections. Now, if you are fairly new to class 4 laser therapy, you are aware that at higher power settings and depending on the delivery technique, there can be a small amount of tissue heating. And so, a very common observation, and it's a good question to bring up, what about tissue heating? If I have that acutely sprained ankle, should I be using my class 4 therapy laser on it? Well, the answer is yes, you should, because with the proper settings and the proper treatment technique, there is no tissue heating. So something that frustrates me to no end is to see um, um, lecturers on laser therapy who are, trying to sell a class 3 device or who are not educated about proper delivery with a class 4 therapeutic laser. To some extent, shame on them because they are misleading people when it comes to the proper use of class 4 therapeutic laser. So here we see an example of this, courtesy of Advanced Health Franklin in Franklin, Tennessee. They are lasering this acutely sprained ankle. I believe this was once a day for 4 days in a row. Apply laser therapy as soon as possible after acute injury, and you will help with resolution of the healing, resolution of the inflammation. The swelling will go down, and you will create tissue healing in the area. So we'll jump gears a little bit and look at some of the mechanisms of photobiomodulation. Now, the great thing is that in the last 10 years, there's been a exponential increase in the number of studies produced on laser therapy. And then also our understanding of the mechanisms of laser therapy has grown exponentially. This is one of my favorite papers, and they talk about all of the effects, the beneficial effects of laser therapy. And in this paper, they have this a chart that shows all of the stages of wound healing that laser therapy is able to act upon, whether it is immediately after the injury, inflammation has been shown to be modified and reduced, all the way through days and weeks and months afterwards. So the key point here is that laser therapy benefits all stages of wound and injury healing. And I point out with my red arrow there, this is a very highly referenced article. So they do have numerous references for you to look at. Another one of my favorite slides is this. This is borrowed from my friend, Dr. Praveen Irani, who is one of the top world researchers in photobiomodulation. He is at the University at Buffalo in Buffalo, New York, and he does use a SUMAS device in his research at the University at Buffalo. I like this slide because it points out that there are numerous mechanisms that are known and studied when it comes to photobiomodulation. Now, if you attend a laser therapy lecture, the thing that we most commonly hear about is the effect of laser on the cytochrome oxidase enzyme and the upregulation of adenosine triphosphate ATP output. But realize that there are many, many more mechanisms beyond that. So we do have the intracellular effects in the mitochondria on the cytochrome oxidase enzyme and other mitochondrial enzymes, creating local increases of nitric oxide and the whole secondary cascade of benefits of increased tissue levels of nitric oxide. There are also mechanisms involving the photoreceptors in the cell membrane, and this is one of these. The effect on the TRPV1 channels was discovered by Dr. Arani at the University of Buffalo. So realize that there are photoreceptors and ion channels and other receptors in the cell membrane where laser therapy is proven to have an effect. And then there are also extracellular effects. So look down towards the bottom of the slide and you see where it says inhibit or promote. We use the word photobiomodulation. Modulation means that if there are processes in the body that are overactive, the PBM treatment can actually inhibit them. Whereas if there are processes in the body that are underactive, PBM treatments can promote them. So modulation, if something is underactive, we bring it up to the proper level. If something is overexpressed, we bring it back down to the proper level. Photobiomodulation, wonderful term. So why is it so important for us to understand the mechanisms of photobiomodulation? Well, three main reasons are here. We gain greater acceptance from the healthcare community at large. My vision of this, my vision is that class 4 laser therapy will be an integral modality in all fields of healthcare. Right now, we have a lot of use in chiropractic offices, pain management offices, sports teams, physical therapy practices, as well as in veterinary medicine. But my vision is that we will see these class 4 therapeutic laser devices being used in all fields of healthcare: dentistry, pain management, wound healing, hospitals, so on and so forth. The second take home message on why we need to understand mechanisms is to optimize parameters for studies. You know, in the last 10 years, we have seen an exponential increase in the number of studies produced, and this ball is going to keep rolling. So understanding these mechanisms will help us to optimize parameters for studies. And then understanding these mechanisms also helps equipment manufacturers, such as us at Sumas Medical Laser. It helps us to build better equipment. Sometimes I look at some of the laser equipment that's being used. I was just at a CE seminar last weekend, and I look at some of the laser equipment that I see. It's literally late 1970s or 1980s technology. So having been around for nearly 40 years, 40-year-old technology, and I'm like, whatever. But it is so important that we continually build better equipment. And with Sumas Medical Laser, even though we are the elder statesman of laser therapy in the United States, we are also continually advancing and developing better equipment. So now we'll take a peek at a few small animal studies. And my take-home message here: photobiomodulation, as I just said on Dr. Arani's mechanism slide. In this study, they are taking the small animals and inducing intestinal ischemia reperfusion injury. And that process of cutting off the blood flow, waiting a little while, and then allowing the blood flow to return, that is a pro-inflammatory event. Now, the exciting thing is they found that laser attenuates acute lung inflammation, and it's able to do this by favoring the production of interleukin 10 and reducing the production of tumor necrosis factor. So once again, laser is increasing the good guys, decreasing the bad guys. This modulating effect, this dual action, this dual effect is so amazing. Another small animal study I like is looking at crush injury on the rat sciatic nerve. And in this case, they recommend that laser therapy should be started as soon as possible after peripheral nerve injury. So that's your very important take-home message. If you're going to be using laser therapy in your practice, number one, you should be using it after any acute injury instead of ice, but then also educate your patients. Educate your patients. If they do have an injury, a slip, a fall, trauma, motor vehicle accident, whatever it is, if they have a trauma, you should be applying laser therapy to that injured area as soon as possible. And another one I like looking at the effect of laser on acute Achilles tendon inflammation. Laser therapy showed a significant superiority over commonly used anti-inflammatory agents. In other words, laser is much, much greater. Laser is much, much better than non-steroidal anti-inflammatories. In this small animal study, what they did was took these small animals and cut a flap of skin and then reattached the flap of skin. And instead of shining the laser light directly over that flap of skin, they applied the laser to the iliolumbar artery, which is supplying that skin. In other words, they are applying the laser proximal to the area of injury. And in this small animal study and in numerous other studies, and also years and years of clinical experience, the phrase that we will use is that you need to laser from proximal to distal. And that is such an important take-home message. You always, always apply the laser from proximal to distal. Sometimes I say that I wish I had a nickel for every time I've used that phrase, because I do use it quite a bit. So we're talking about using the laser from the center of the body outward, and we're doing this for many reasons. The influence of the blood on the blood supply to the area, the influence on venous and lymphatic return from that area, the influence on the nerve supply to the area. And if I can pull up my highlighter here, and just to show you, I'm indicating it's not, if we're going to be working in the lower extremity, and let's pick on the left lower extremity. If I am working on this patient for any condition affecting the lower extremity, my application of the laser should not be a rapid up and down motion like that. Now, that's going to help the patient, but it's not going to do the best for them. You want to do the best you can for your patients. So do not do it up and down like that. Rather, get the patient into a comfortable position where you can comfortably apply the laser circumferentially around the extremity, and then you are very, very gradually progressing slowly distally down the leg, down the lower extremity. So when we apply the laser properly like that, it's going to give us the best outcomes. And once again, for the reasons that I list on this slide. Take a little bit of a look at the use of laser on various wounds. And let me just comment that if you are a chiropractic office, if you are a chiropractic practitioner, obviously wound care is not in your scope of practice. However, it is okay to use laser therapy for the pain in the area. A couple of studies here. This one looking at the additive enhancement of wound healing in diabetic mice by using low-level laser and topical CoQ10. So we're going to see a collection of wound pictures on the next slide. And you see that they are in the top row having the control. The second row is the group where they applied a topical CoQ10. The third row, the group where they applied laser. And then in the bottom where you apply laser in conjunction with CoQ10. So if you do have a open wound that you're dealing with, it's recommended to use either CoQ10 or ubiquinol supplement. And I'm not, I'm not brand specific when it comes to any nutritional supplementation, but find good, reputable, professional suppliers for your nutrition. In this example, I have these gel capsules where I would simply poke a pinhole in the gel capsule and then just squirt that into the open wound. So it's very easy for us to see this happening with this superficial wound, but realize that also internally, any kind of internal healing, your laser patients will benefit from the supplementation of ubiquinol, especially if they are taking a statin drug. Especially if they're taking a statin drug, they should be taking ubiquinol. Now, I didn't want to gross everyone out and show a whole bunch of wound pictures. I just didn't feel like putting that in my presentation today, but I do have them. This study looking at the efficacy of class 4 lasers on non-healing neuroischemic diabetic foot ulcers found that laser therapy delivered with a class 4 therapy laser can significantly impact the healing process. So this is a study that I played a role in developing the protocols for it. Just essentially, what did we do? Yeah, it shouldn't take, should be fairly easy to guess. We apply the laser proximally first to have that influence on the blood supply to the area of the wound, proximal to distal. And then, yes, we did apply some laser directly over the wound itself. Now, I really like this set of pictures. These pictures are sent to me by a friend of mine, a doctor in northern Wisconsin. And this is a patient that is suffering from diabetic peripheral neuropathy and peripheral arterial disease. And I love these pictures because it shows us immediately before, during, and after the treatment with the Suma's class 4 therapeutic laser. You can easily see the benefits. And I just love this set of pictures. Now, in the middle, let me just say that normally she would have the treatment wand directly in contact with the skin surface, but she just tipped it up a little bit so we can get a picture and so we can see the red and infrared laser light. But imagine, look at that amount of increase in blood flow and improvement in tissue health immediately before, during, and after this laser treatment. This patient was also able to get significant reduction in their symptoms associated with diabetic peripheral neuropathy. A few comments about brain and head. A very nice paper written by Michael Hamblin, who was at the Wellman Center for Photomedicine, and he's also at Harvard Medical School. So sometimes when I come across a skeptic, I, I, I don't find too many of them anymore, but if I do find someone who is skeptical about laser therapy, I point out that at Massachusetts General Hospital, at Harvard Medical School, they have a whole division, the Wellman Center for Photomedicine, a whole division dedicated to photobiomodulation research. And I like this article because it points out that there is some evidence that all the seemingly diverse conditions, and so it's going to be traumatic events, stroke, traumatic brain injury, and global ischemia, or degenerative diseases such as dementia, Alzheimer's, and Parkinson's, or even psychiatric disorders such as depression, anxiety, or PTSD. There is evidence that all these seemingly diverse conditions can be beneficially affected by applying light to the head. So that should be something to give us great um, confidence in the future in the possibility of laser therapy being able to have an effect on all of these different brain-related conditions. Now, just one comment here, take-home message here. If you are going to use your class 4 therapeutic laser over the head, yes, you can do it. The one thing we have to do, and I just want to caution you against this and make sure we do this, rule out intracranial bleeding before applying lasers to the brain. It is proven that infrared laser light will increase circulation in the brain. So applying the laser across through the skull will increase intracranial blood flow. And so if the patient, say for example, had a concussion, traumatic brain injury, hemorrhagic stroke, they could possibly have some bleeding on the brain. Make sure that you rule out that intracranial bleeding before you apply the laser to the brain. Now, this study looking at the use of multi-watt treatment for the neurodegenerative treatment for traumatic brain injury. I think in this case, they were using a 10-watt therapeutic laser. But the main point here is that class 4 laser therapy is safe and effective treatment for the brain. And in fact, when you look at the depth of penetration studies, yes, laser will actually penetrate the skull. A very small amount will. Penetration studies show that around 8 to 10% of that infrared laser light applied on the outside of the skull will be able to pass through and into the brain structures. So here again, occasionally I hear people lecturing on laser and saying that we should not be using class 4 therapeutic laser over the brain because it'll cook the brain. That is just so ridiculous and disappointing, and shame on those people. In fact, it should be the opposite. You can argue that you need to have a class 4 therapeutic laser, knowing that our penetration through the skull is only about 8 to 10%. A little bit of information on peripheral neuropathy. A couple of studies here, one looking at peripheral neuropathy associated with chemotherapy, and another with peripheral neuropathy associated with diabetes. And the main point here, class 4 laser therapy helps patients with the symptoms associated with peripheral neuropathy. We get significant reduction in pain, significant reduction in neuropathy symptoms. So when we think about either diabetic or chemotherapy-induced peripheral neuropathy, that is a condition that modern medicine does not have an answer for. If a patient has diabetic peripheral neuropathy and they go to a standard medical practitioner, they will simply get prescribed opioids, pain medication, the various other anti-seizure medications, gabapentin, Lyrica, Cymbalta, etc. They do nothing. They do nothing to help with the symptoms associated with neuropathy. And so over the past few years, we have found that class 4 therapeutic laser is a solution for these patients. For about 5 years now, we at Sumas Medical Laser have been teaching a weekend seminar. We call it the Neuropathy Treatment Center, NTC. And over that weekend seminar, we cover everything that the practitioner needs to know about examining, diagnosing, identifying, testing the neuropathy patient, treating, how to do laser treatments, how to implement the NTC concept into your office, and how to make sure that patients sign up for the care that they need. So your take-home message here, class 4 laser therapy helps patients with peripheral neuropathy. Treatments are safe and effective. So as you see, a couple of quotes from the study, no observed complications, and nearly 90% of patients experience significant improvements in MTNS scores. Just so important. It is so important. A couple of other conditions that I just picked out here. We do have a study from 2020 that looks at laser therapy attenuating lung inflammation in the mouse model of idiopathic pulmonary fibrosis. Well, if you are interested in the use of class 4 therapeutic laser in human patients with idiopathic pulmonary fibrosis, I encourage you to go to the website ipflaserstudy.com. And on that website, you will be able to read the story of Dr. Andy Hall from Sonoma, California, and how he was self-diagnosed, or he was diagnosed with IPF, and reasoning that he really had nothing to lose, he decided to self-treat himself with his class 4 therapeutic laser. Okay, so when I talk about oftentimes the things that we do in the real world, in the clinic, is sometimes years ahead of what is shown in studies. Dr. Hall was diagnosed in, I believe it was 2014 or 2006, is 2014. Dr. Hall was diagnosed in 2014. He started to treat himself. He had such an improvement. His pulmonary function tests were either staying steady or improving. With every succeeding test, either staying the same or improving. And if you know anything about the natural progression of IPF, you know that it is a disabling condition where the patient's condition slowly gets worse as you get more scar tissue growing in the lungs. So Dr. Hall was treating himself starting in 2014, and once again, this study comes out in 2020. If Dr. Hall had waited for this study to come out, he would be deceased. But now, after 7+ years of treating himself with his class 4 therapeutic laser, his health is good. He is part-time in practice. He enjoys hiking and biking, and he even does activities at elevation, at high levels where the oxygen content is lower. So once again, if you're interested in IPF for human patients, go to the website ipflaserstudy.com. Just a couple of other interesting ones. A paper that came out in 2005 showing that nitric oxide inhibits the replication of the coronavirus. Well, going back to our mechanisms of photobiomodulation, nitric oxide dissociation is a very well-known mechanism of PBM. And now we are seeing, and there are papers out there that PBM treatments do have high potential for treatment of lung problems associated with the COVID-19 infection. So I went through just kind of a summary of various studies and information and tried to give you take-home messages. If you want to browse our online research library, you can go to medical.sumislaser.com, medical.sumislaser.com, and there we have various studies organized by science, musculoskeletal, neurological, superficial, and other topics. Let me just point out, if you do go to this online research library, there may be cases where we're only allowed to post the first page of the study, which is going to show you, the title, the study goal, and the methods, the results, and the conclusion of the study. So on some of those, if you click on them, you may only see one page of the study. Okay, so there you have it. Review of photobiomodulation literature, plus real-world clinical experience, your implications for treatment plans. I've really enjoyed presenting this webinar to you folks. Thank you so much for being here with me today. My name is Phil Harrington. I'm the medical director for Sumis Medical Laser. I welcome any of your questions or comments. Thank you so much, old friends, for joining us today. And if we haven't met yet, I hope we can meet sometime in the near future. Thank you so much, folks. Thanks for being on, and have a good rest of your day.